Hello, everyone, and welcome to episode 22 of the Rogue Health Economist. I'm super excited to have here Dr. David Katz to talk about total harm minimization. And Dr. Katz, I guess I just want to start by saying I want to acknowledge you. I first heard you speak in 2008 in New Haven. I just want to acknowledge your remarkable consistency with which you've treated all the issues in healthcare. And I guess I just want to start off by asking, I feel like the positions that you've held for the last 12 years have been not that controversial. You've been talking about lifestyle, and I guess I also want to acknowledge you have a fierce protection of the social determinants of health and understanding of the social determinants of health that have led to your position in lifestyle medicine, preventive medicine. And so what's it like for the ideas that you've shared to be somewhat controversial at this moment in your career?
Well, first of all, thank you, James. Yeah, it's remarkable how controversial being non-controversial has become. I think the simple fact is, in a highly polarized world, in a highly polarized society, when you consistently are willing to look both ways and you see a truth in the middle that hybridizes insights from both sides, I think in a more reasonable world, in a more civil world, in a world where we're accustomed to listening to people we don't necessarily agree with at the start and we're willing to be persuaded, I would be a very non-controversial guy. I think I might even just be flat out boring. In our world, I'm a lightning rod because, nobody's willing to look at the middle. Everybody's in opposing corners, and you are an iconoclast by saying the most centrist, temperate, moderate things of all, like, in a pandemic of infectious disease, the virus can kill people, and shutting down society can kill other people, and killing people is bad either way. Where is the controversy, right? I mean, what have I said so far that anybody could object to? So sort of shocking to me that the position I was staking out, which, as you say, is completely consistent with everything I've done over the expanse of my career, proved to be controversial. I'm glad it proved to be influential. And, frankly, when you're in the business of putting ideas out in the public domain, you want to make people think. And sometimes the cost of making people think is making people uncomfortable because they have to think about stuff they haven't already thought about. They have to think about opinions they didn't already own. And when you make people uncomfortable, the first thing they do is lash out at you. That doesn't mean you're not getting through. It doesn't mean that in the end, the sensible arguments don't win, but you have to have a thick skin. You have to be willing to weather the early going, which is tough. But yeah, I can describe myself, I think, as an anti-iconoclast who, by virtue of that, is an iconoclast, as an anti-contrarian who somehow seems contrarian, and as the world's least controversial, most boring guy who keeps saying the same things over and over and over again, who's suddenly wound up controversial and notorious. So yeah. Strange world.
It's interesting. Has your position opened up ecosystem players to ideas about lifestyle medicine, and has this virus pandemic opened up to doors that were previously closed?
Well, in terms of my commentary on COVID opening up doors, for sure. I've spoken on news outlets that would never have called me before. I've reached audiences that would never have listened to me before. And I've made friends that I'm glad to have made. And frankly, I think I've made friends of differing political stripes and differing ideologies. And that's a good thing. I mean, you basically want people who don't all own the same opinion at the start, willing to talk, willing to listen. And I think that's happened. All that's great. In terms of lifestyle medicine specifically, I think it's too soon to know for sure, but everywhere I could take the message, I've begun taking the message that there's never been a better time for lifestyle medicine. There's never been a better time for a national, global, let's get healthy campaign. There's never been a better time for that to be a personal priority, because there's the issue of time, timing, and timelines. And what I mean by that is, humans perceive threats that come at us fast. We're hardwired to do that from our experience on the savannah and evolutionary biology. Predators, red in tooth and claw, they scare us. Venomous snakes scare us. Type 2 diabetes, coronary disease, obesity, not so much. They're just too slow. They don't activate the fight or flight response. So diet kills 500,000 people prematurely in the United States every year because it's so much worse than it ought to be. 500,000. So 100,000 deaths from COVID, tragic? Absolutely. But 500,000 people die prematurely of diet, something we completely control, every year.
Mm.
Tragic? Hell yeah. Why are we not outraged? Why are we not having massive societal reactions to that? Because A, it's familiar and therefore we're contemptuous, and B, it plays out in slow motion and it doesn't tickle our adrenal glands and it doesn't activate the fight or flight response. What COVID does to that whole situation, James, is takes these chronic liabilities that you and I have devoted our careers to and made them acute concerns, because you're at higher risk of dying of COVID tomorrow if you have obesity, if you have diabetes, if you have heart disease, if you have all this stuff that has been the major burden on health all along. But all of a sudden there's a whole new motivation to fix it. And the good news for us who've been in this camp all along is that you can get an acute benefit relative to your immune function, immune system balance, your response to COVID. And it's the gift that keeps on giving, because if you make yourself healthy because of acute fear, you've made yourself healthy. And you know, that's going to be a benefit in the long run. So I'm hoping collectively we do wind up making a very large barrel of lemonade out of the pandemic lemons.
Yeah, absolutely. I think that's really exciting. I think also something that you hinted at there is that this sort of concept of total harm minimization is a little bit impalatable when it should be obvious, because a lot of the deaths associated with the the social determinants of health have yet to happen.
That's right. Yeah, I actually, as we're having this conversation, I did a webinar. I think it was yesterday morning. It just happened very recently. I sort of, everything's a blur. You know, every day in the pandemic is a month. Every week feels like a lifetime. But I just did a webinar for the Chan Zuckerberg Initiative um, out in Berkeley, and I did it with Nick Bloom, who's a health economist at Stanford. And Nick presented some excellent slides on the ultimate mortality toll attached to unemployment. So, you know, basically there are good prior studies showing that you tend to lose a certain number of years from life, 1.5 years or more, um, associated with periods of, you know, being laid off and unemployed. He did the math and said it looks like, you know, it's going to take a while for this to play out, but the cost in lives of 40 million people unemployed in the United States, we project could be something like 20 million person years of life lost. Now, he compared that then to the direct loss of life for COVID. So, you know, we're told that on average, COVID is taking 10 years from life. I actually suspect it's less, because a lot of the deaths are in nursing homes. But let's say it's 10 years and 100,000 people. So that's a million person years. We may lose 20 times as many years of living as a result of unemployment as from the direct cost of the infection. So this was never, what made this controversial, James, was the idea that there was, you know, some discussion about trading off human lives and dollars. Absolutely not. I'm not an economist. I'm a public health physician. It was all about human lives. And then the other controversy was, well, wait a minute, why are you opining? You're not a world leading microbiologist, virologist, pandemic response expert. And my answer to that was absolutely true. But all the people who, you know, drop into hot zones in hazmat suits do not devote their careers to studying chronic diseases, social determinants of health. No one person is expert in it all. But some of us have to be willing to drop back, look at the big picture and say, wait a minute, you know, we may be focusing on one part of the body, but killing the patient. And just like we do that sometimes in hospital care, we can do that in public health. And I didn't want to see that happen here.
Absolutely. It's almost like the endocrinologist isn't going to solve the type 2 diabetes epidemic, even though he could help someone with type 2 diabetes.
Exactly. So, you know, again, and this is just my native tendency. It figures in the talks I give, it figures in the research I've done, and it's a big part of my whole professional agenda. I am a forest guy. I see the big picture. I often start talks with the blind man and the elephant, which is a parable about the dangers of just seeing one small part, right? Each of these 6 blind men takes hold of a different part of the elephant and reaches a completely different conclusion about what kind of animal it is. You have to step back to see the whole thing, the famous elephant in the room. So in this case, that's all I did. Step back, looked at the data, said 2 things are really important here. One, this disease is clearly very different in vulnerable people and healthy people. So elderly, frail people, it's a terrible disease. It deserves all of our respect. Young, healthy people, 99.98% of the time, it's a mild disease. Shutting everything down to protect them is unnecessary. Doing everything we possibly can to protect the highly vulnerable is absolutely essential. I think if we protect everybody, we won't do a good enough job here. And by protecting everybody, we may hurt people because we will shut down society and we will lay off people and we will have 40 million people unemployed. And here we are. So I think we actually have, because it was a haphazard approach, compounded the harms of the contagion, which are real and deserve every measure of respect, with the harms of misguided interdiction efforts that were not optimally effective and misdirected. So they may actually have done more harm than good. They certainly harmed people who they didn't help.
Well, I'll just throw in as an example there, and you're right in the sort of geographic area of this. Can we just throw in putting infected people into nursing homes as a policy, right?
Yeah. So the thing with nursing homes, and I've been, and by the way, when I started to comment here, I was conferring with colleagues as I always do, but I also was just drawing on my own training in epidemiology and public health, where I am well trained, and my tendency to see the big picture. But since then, I mean, after I published my piece in the New York Times, and Tom Friedman has channeled my column into his commentaries a number of times, a who's who in this space is family. So I routinely am getting advice and guidance and input, from world leading experts. I mean, the greatest microbiologists and virologists and pandemic response experts and all of that. So, very well informed at this point. And I continue to believe that we're failing to protect the most vulnerable the way we should. Among those experts are people who've devoted their careers to nursing home care, gerontologists who study this. And, frankly, the data are very compelling. In my home state of Connecticut, James, 60% of the mortality, the total mortality from COVID, is just in nursing homes. Tiny sliver of the population, 60% of the COVID mortality. In Ohio, my friend Mike Roizen at the Cleveland Clinic tells me it's 72%. The national average is above 50. In other words, we could cut the total mortality of this pandemic in half just with meticulous protection of nursing homes. So, I mean, what a massive failure then to protect the most vulnerable, and what a massive misallocation of resources to, shut down every university where, there were going to be extremely rare cases of severe infection, shut down every school. So we did a lot that wasn't helpful, and we haven't done nearly enough where it's most important. One of the things we need to do next is adopt truly rarefied protection measures for nursing homes. I've been working with colleagues on detailed policies, what that would entail. We know what it would look like. We have the resources to do it. We just have to get it done.
Beautiful. Well, let's look a little bit to the future. Obviously, we have states opening up right now. There's some data from some states looking at seeing what happens when that happens. Obviously, in Europe, you have whole countries that have opened up in the last month, and we start to see those numbers. What do you expect to happen this summer, and what do you expect to happen later this year with regard to a quote unquote second wave?
Well, so I know what we should be doing. And by the way, I think this is important to note, because I've been accused of being an armchair epidemiologist. I'm a clinician. I did, better part of 30 years of patient care, but I retired from patient care a few years back to focus on public health. But I came out of retirement to volunteer in New York City, and I did several 12-hour shifts in an emergency department in the Bronx. And I've seen people with COVID, I've seen people intubated with COVID, and I've seen people die of COVID. And so, I know what this looks like, and I know how scary the bad versions of this disease are. So it's with my perspective, both on public health and the clinical side, that I say what we should do is absolutely focus on total harm minimization, not shut down more of society than we need to, but also not open up society haphazardly. It would be a huge mistake to let, 80-year-old people go out and not be concerned about exposure to this virus. So I think we ought to focus on total harm minimization. We ought to risk stratify the population. I think to the extent possible, we ought to make tools available to individuals to know their personal risk. I think policies, programs, and practices like wearing personal protective equipment, like social distancing, should vary with your risk tier. I think we should have guidance for people who are low risk but live with somebody who's high risk. Some of this needs to be governmental policy. Some of this can be your employer, your university, your school, your church. But I think some of it also ought to be you. You ought to be able to know, what is my risk? If I get this thing, what is the likelihood of me getting a severe case of it? And what can I do to reduce that risk? The other thing is people ought to learn a little bit about dose, because dose matters. If you're exposed, but you're exposed to fewer viral particles, you're much less likely to get an overwhelming infection, much more likely to make antibodies. So that I know what we should do. What's going to happen? Will there be secondary waves and so forth? Nobody knows for sure. We can all be hoping not. But to the extent that we did shut everything down and lock everybody in and hide from the virus, that flattening the curve doesn't prevent anything. It basically postpones, because everybody's still vulnerable. The virus is not going away. It's out in the world now, established. So we will get exposed. And if a vulnerable population that wasn't formerly exposed gets exposed in the future, we will see new spikes. So how do you avoid bad things happening? How do you avoid lots of deaths then? How do you avoid overwhelming the medical system then? Well, minimally, you stick with your vertical interdiction. You do ongoing monitoring, ongoing surveillance. When you start to see an uptick in cases, you double down on protecting the higher risk groups, because it's the higher risk groups who need hospital beds. Again, 98, 99% or more of all the people who get this infection have mild infections. They recover at home. A sizable portion of that total group has no symptoms at all. You don't need to do much to protect people who have asymptomatic infections, but you have to keep sheltered from them the people who are likely to wind up in the hospital. So we need to be light on our feet. We need to be protecting the highly vulnerable, nursing homes especially, until we get to herd immunity, vaccine, or the all clear by one of those means. But whatever it is we do, we have to have a supply of personal protective equipment available. We have to have hospital capacity available. And we have to be prepared to respond to episodic, isolated surges in cases, which may happen and nobody can say for sure.
Interesting. I've heard a little bit of chatter about sort of potential longer term consequences of infection beyond just the first wave. Is there any data to support that in your experience and your read?
Well, data, it's hard to say, because we have no data about long-term anything, given that the whole pandemic is really just a few months old. So, everything beyond what happens over the first few months is informed conjecture. But there's no question that some of the people that the virus doesn't kill, but it almost kills, are really sick for a really long time. And some of them may never fully recover. But that's true of every major bodily insult, a severe trauma, a bad car crash, a terrible bout of the flu, bad pneumonia. So yes, I fully expect that some people who've had this virus, were in the ICU, recovered, may not fully recover. But let's say two things that are really crucial. One is, every bad outcome associated with COVID for weeks and weeks and weeks has made national news. And as bad as this is, and it's bad and it deserves our respect, it's not that bad. It has a distorted portfolio of exposure. If every time someone died in a bathtub in the United States made national news, we would have a national moratorium on bathing. And I'm not being facetious. I really mean, we'd be hearing every day of someone, and in particular children, dying or drowning in a bathtub. We'd say there can be no more bathtubs in houses. And maybe there shouldn't be, but the simple fact is, the likelihood of a child dying in the bathtub is extremely remote, but in a population of 330 million, remote things happen every day. And if they populate the national news every day, you get this massive distortion of what the real risks are. So yes, there will be some people with permanent consequences of COVID infection, but for every one of them, how many had the infection and had no symptoms or barely any symptoms and became immune and oblivious to the fact that they ever even had the thing? Yeah. Maybe thousands, maybe more. Until we really have good information about the denominator, we are much more likely to exaggerate the risks than to fail to perceive them. And the problem is that creates a sense of outsized terror about this one thing. And that leads me to the other main conclusion. You asked me what needs to happen next and what do I think is going to happen next. So, what will happen next is anybody's best guess. But the best way to predict the future is to create it. And that part of it, I'm perfectly happy to own. And so we have a massively higher degree of vulnerability to severe SARS-CoV-2 infection than we need have. We can't do anything about our chronological age, but we can do a whole lot about the burden of chronic disease. And it's very clear that the stuff that was already taking the most years from lives and life from years, so poor diet, lack of physical activity, obesity, diabetes, heart disease, heart failure, cerebrovascular disease, all of that massively increase the risk of bad outcomes if you get COVID. So we absolutely should be focusing on this opportunity to improve our personal health, to improve public health as an acute response to the pandemic. I mean, that's part of minimizing total harm. So it's not just risk stratification. So I've talked about vertical interdiction or risk stratify, direct our policies there so that, basically the protection matches the vulnerability. But we can change the vulnerability, and that's a step better. So you're in a higher risk group, you can migrate to a lower risk group with lifestyle as medicine by improving your diet quality. We're in that game at my company, Diet ID. We've made the tools that we offer we're a business to business company, but we've made them freely available direct to consumer. So people can see, what is my diet quality? How does it compare to a diet that's optimal for immunity? What's the delta? What's the gap? And what specific things to me would help me get closer to that? But I think a lot more resources like that, ideally, would be part of a national Let's Get Healthy Now campaign, because it's an issue of national security. And it's the best way for us to reduce the toll of the pandemic. And it's the best way for us to reduce the far greater toll of chronic disease that was with us before and will be with us after.
Yeah, I want to really dive into that. I saw somewhere else that you said you're actually 57, but your immune age is 40. So what are the things that go into that calculation?
Yeah, so I used a risk calculator that was developed by associates at Everest Health, and I like it very much. And they're working on, disseminating this. And you enter your chronological age, you enter your sex, you enter your height, your weights, your BMI is calculated, your waist circumference. It asks you if you know your blood pressure. It asks you if you know your hemoglobin A1C, which if you have diabetes, you will, and if you don't have diabetes, you won't. But anything you don't fill in, it basically just defaults to a neutral value, so you don't have to fill everything in. It asks you if you have lung disease. It asks you if you have immune disease. So lots of detailed information. But any field you don't know, you skip. And each thing you enter, it translates that into an adjustment of your chronological age into a biological age, and then further translates that into your specific risk. If you were to get COVID-19, what's the percent probability you would get hospitalized, the percent probability you would wind up in the ICU, the percent probability you would die. And then it further can translate that into, okay, your risk, you're a healthy young person, your risk is very low. These risks are roughly comparable to the risk of needing hospitalization because you commuted to work for 3 months. That sort of thing, where it puts it in a perspective where you can say, okay, that's what that means. So I don't balk at the idea of going to work, because there's some measurable risk that after 3 months of driving back and forth, I'll be in a crash that puts me in the hospital. Living involves risk, right? We're all at risk of something happening. So yeah, my COVID specific biological age was almost 20 years younger than my chronological age, because no big surprise, I'm a health promotion specialist. I eat optimally, I'm physically active, I'm lean, I don't have any major chronic disease, my blood pressure is fine. But again, I'm not special. Everybody can move in that direction.
Let me ask you about that. So on the individual level, what is the speed at which someone can actually reclaim their immune resilience from a place of lower levels?
Just the right question, James. Fantastic. So I would say, the more time you have, the better. And obviously, if you spent a lifetime being unhealthy, the idea that you could just flip a switch and suddenly be perfectly healthy is a bit far-fetched. But over the years at the Prevention Center at Yale, we studied endothelial function, which is, by the way, seemingly a very important pathway in the pathophysiology of COVID, and just fundamentally important to total body systems. It's control over the lining of blood vessels. It ultimately influences the health of every organ system. And we've shown that it can change pretty dramatically with a single meal. In other words, what you eat for lunch today will influence your vascular health this afternoon. There are also studies of chemotaxis, basically cell culture studies that look at how white blood cells of the immune system react to stimulants, that show the same thing, that reactivity to potential threats can shift and change with dietary intake, physical activity, and hormonal balance that fluctuates over the course of a single day. So I don't think it's at all far-fetched to tell people you can begin changing the balance in your immune system, the health of your vascular system, and your potential defense against a bout of SARS-CoV-2 if you get exposed immediately by choosing to do better in your next meal, by going for a walk today instead of staying on the couch. That effect will be modest with just one meal or one walk, but it will be meaningful just the same. If you amplify that not into a single meal and a single walk, but several days, that benefit goes from being measurable to being genuinely meaningful. And I would argue that you can probably approximate something like a 180 in just the span of weeks. So, it's not a really remote goal. And again, if you spent decades of your life living really badly and you have major health problems, it'll take longer to reverse them. So it sort of depends where you're starting. But if you're starting, you have blood pressure elevation, or you have type 2 diabetes, or you are overweight, or you do eat a lot of junk food, or you are inactive, or you smoke. All of that is addressable immediately, and the benefits start to accrue immediately. They aggregate, they amplify over time, but there's an immediate benefit. So it's never too late. It sure as heck isn't too early. And the more you do and the longer you do it, the better. But here's the good news, James, as you and I both know, this isn't just about dialing down your risk of COVID. This is about dialing up your vitality for the long term too. So you do it immediately because you want an immediate benefit, and then you stick with it because that benefit grows and you start deriving additional benefits too.
Well, that reinforces, my efforts and my goal to spend the next 10 years of my life realigning health systems around getting groups of people to support each other in facilitating that kind of transformation. I guess I want to just finish because I know we have to wrap, but you've stood up at a time that it wasn't kind of like the easy thing to do and talk about these kind of things. And there's the naturopathic community and the lifestyle community and the functional medicine community and the sort of integrated medicine community. What do you think is the importance of clinicians in those spaces at a local level, maybe not at a national level, to talk the talk that you're talking right now?
I think it's really important. I believe wholeheartedly in the importance of solidarity and consensus. Not that all of us need to agree about everything, but because we're such a polarized society, and because everything reverberates through both traditional media and in particular social media, and because you can go shopping online for the opinion you already own, and it's easy to wind up in your tribe and oppose every other tribe, I think it's really important for us to come together across disciplines when we agree about most things, right? So, these disciplines are separate because we do have some differences. But if we agree 80% about what's most important, let's put the 20% to the side right now, come together, and let's say, here's the part we all agree on. And as you know, I created the True Health Initiative for that very reason. And by the way, that's where we've archived all detailed materials about total harm minimization and risk stratified interdiction. So people can go to truehealthinitiative.org to learn more. But we created that as a place where people with very diverse perspectives could come together and say, I prefer a vegan diet, I prefer a Mediterranean diet, but we agree overwhelmingly that the best diets are real food, not too much, mostly plants. We agree about 90%, 95%. All you ever hear us talk about is the 5%. I think A is best, she thinks B is best. But, again, you never hear us say, yeah, but 95% of A and B are the same. So I think, what you just described, all these different disciplines that care about this, that care about leveraging lifestyle as medicine, that care about treating the root causes, that care about the value proposition of disease prevention, health promotion, that believe the right measure is vitality, overall vitality, not the prevention of just one disease. Now is our time to come together and say this high level of vulnerability to the pandemic is not necessary. We ought to do all we can to prevent a next pandemic, but there may be one. Let's not be as vulnerable next time. There may be recurring waves of this. Let's not be as vulnerable if there are. Let's take advantage of the lessons in this pandemic to get healthy. And, we all agree that there's a huge opportunity. We all agree about the fundamental components. We all agree that diet is critical, physical activity is critical, not smoking is critical, managing stress. Again, you look across these schools of thought that you just mentioned, overwhelmingly our platforms align. If it were a Venn diagram, that spot in the middle where we all come together, would be big, and it's what's most important, and it's leverageable right now. So yes, I think this is the time to bring those communities together. So I'm counting on you to make that happen, James.
Well, it's funny you say that, because I am literally going to make that happen, or our community is. For the last 6 years, we've been building local meetups of practitioners from across all those disciplines to get into a room together and to have exactly that discussion. And later this year, we are going to be rolling out sort of like a Rotary Club infrastructure for those clinicians, so that there can be a New Haven, Connecticut club and a Stamford, Connecticut club, because ultimately we see that when you put people into community and they actually sit face to face, they realize they're 95% aligned.
Exactly. No, it's great. Of course, these days we're having to do it via Zoom, but
Yeah.
before too long, we'll be back together in real, right. It'll come back. But whether it's virtual or in real space, absolutely. I mean, we're all human. We've all got the same skin in the same game. We all care about the same things. We all love our families the same way. It's so easy, to turn into avatars in social media and forget our commonality. But you're absolutely right. You get people together, you provide some reasonable latitude for dialogue, and you quickly discover how much you agree. And you want to champion those causes that matter to all of you. Tremendous opportunity. So thank you. I think that's yeoman's work. That's great.
Well, thank you very much for your time today, and thanks for, again, your remarkable consistency with your principal work. And I'm very excited to be sort of following in your draft to be able to make a bigger impact and support the journey. So thank you so much.
Thank you, James. Good to be with you.
Thanks, Dr. Katz. Take care.
You too. Be well.